Welcome, everyone. My name is Chris Hall. I'm from the Center for Excellence in Collaborative Education. I want to thank you for joining us for our event today. Our event is Talk to Me, Look at Me, Know Me, Improving Communication Between Providers and Persons with Disabilities. This event has been co-created by Matt Postolowski and Roshan Patel, two Doctor of Osteopathic Medicine students from the class of 22, and they have assembled a terrific panel for you today. We will be putting some resources in the chat and also a copy of the PowerPoint, which you can download at your leisure if you're interested in keeping these resources for later. And I'm going to hand it over to Matt to get us started.
Thank you, Chris. So hi, everybody. Thank you for joining us today. So like Chris said, I'm Matt. Roshan is here as well, and he's going to talk in a second. We're third-year comm students. We've been working on this project with CEC for over a year now, pre-COVID, under the guidance of Dr. Stacy Teamy, who's one of our comm faculty. She was helping us with a research project that was looking specifically at improving communication between healthcare providers, us, and individuals with intellectual and developmental disabilities. So we had some great results that came out of the study. It was a survey that we distributed to caregivers in the local community, specifically around the Portland area. And really the gist of the results were that there were definitely areas where we could improve as caregivers or as providers from the caregiver's perspective. And so instead of publishing our results, Roshan and I thought it would be better to create a seminar, help lead a seminar where we could invite some guests to come talk to us about how we can best communicate with our future patients. And so I'll hand it off to Roshan, and he's going to introduce some of our guests for today.
Hey everyone, thanks for coming and joining us today. So like Matt said, this event today was emerged from the idea that we wanted to educate rising healthcare professionals about IDDs and what we can do to improve the healthcare experience for patients living with them. So to help us out, we've got a small panel of guests to share their experience with working with individuals with IDDs. First, we'll have Candy Garek, who will share her personal experience raising Amy, her daughter who has Down syndrome. Then we're going to hear from Nancy Cronin, who is the Executive Director of the Maine Developmental Disabilities Council. And finally, we're going to talk with Doris Babbage, who is a nurse working with the IDD community as the Director of Adult Nursing Services and Infection Prevention at Spurwink. We also have Maeve Hickey that's going to be joining on with us, and she's mostly going to be monitoring the chat. So if anybody has any questions throughout the presentation, you can feel free to throw those in the chat, and we'll collect them all at the end and answer them Q&A style towards the end of the event. But right now, I'd like to invite out our first guest to speak. Candy is the mother of Amy, who is now a 42-year-old woman with Down syndrome. Candy herself is now retired, but she has an extensive history working with various nonprofit and for-profit boards, as well as regional and state committees. She has served on the board of United Cerebral Palsy of Maine, volunteered visiting families of newborns with IDDs, and has a long history of involvement with the Special Olympics. So, Candy, the stage is yours.
Well, thank you for asking me to do this. I'm going to tell you about what it's like to learn about a child with disability and how that affects a parent, because parents are really having a lot of emotions at the time. I'm going to share with you the where, the when, the who, and the what, as well as how we had to tell people in our circle. First is the where. I'm in the hospital and just given birth to my new baby daughter. I've seen her briefly. She's beautiful with an adorable little face, cute nose, and some black hair. I loved her instantly. My husband, Bob, held her immediately after delivery and gave her a bath. He was on cloud 9. I was tired after having a cesarean section and was drifting out of sleep when the pediatrician came in and told her to weight, length, and APGAR score. She was 5 pounds, 10 ounces, but healthy. Bob left soon after the pediatrician. He was exhausted and went home to rest. When the next morning I was alone in the hospital room, I was cuddling baby girl Durrett, watching her sleep, making squeaking noises and moving her little arms. The pediatrician came in, and I was making a list of names when he came in, and They just told us a few things before he really got into what he needed to talk to me about. I'd only met him once before. He was followed by a nurse who took my baby. In less than 3 minutes, my entire life changed forever. He was calm, speaking with a pleasant voice, and told me my baby was sleeping well and asked me how we were doing with the nursing. After some more chatting, he told me he was doing some follow-up testing. He felt it was a disorder, and he became concerned shortly after she was born. It was a test to determine if she had a genetic abnormality. My reaction to this day, I don't know where it came from. I asked him if he was trying to tell me I had a baby with Down syndrome. Yes, he said. He did it calmly, answered my questions, and tried to be soothing. It was impossible. I remember this memory very clearly. My heart was pounding, I was trembling and scared. I realized after he'd gone, he delivered me that message with very little eye contact. It would have been helpful and important if he had. I called Bob in a panic, telling him what happened and that I needed him. He was able to find someone to take care of our 5-year-old son and drove the 60 miles to the hospital. His emotions were wild too. Once he arrived, we cried together. The nurse brought the baby in and we studied her, looking for anything that made us feel that she had a special needs or a disability. We didn't know Down syndrome had markers, that their little pinky finger would turn in, their palmar crease would not go all the way across the palm. We thought her eyes were beautiful. We didn't realize they were slanted. We didn't notice she had poor muscle tone or loose joints. We just didn't know what to look for. The next day, the geneticist came in. The news was, yes, it was confirmed our daughter had Down syndrome. She was truly a trisomy 21 baby and would have a mental disability. The karyotype showed 21, 3 of the 21st chromosomes. However, her third was stuck to another chromosome, which is called translocation. It's not as common as the trisomy 21 normal. There are 3 types: normal trisomy 21, translocation, mosaic. And the mosaic cells, not all of the cells have 3 of the 21st chromosome. The next morning, we were being discharged. The discharge nurse came and gave us appointments for the follow-up appointments and told us, and hugging me, that the child we expected was no longer our child. Now we had to learn the child God had given us, welcome her into our hearts. Before we left, we had to name her. We decided Elizabeth would be too hard to spell, and I still didn't like Frances. Bob suggested the French spelling for Amy, A-I-M-E-E, which is French for friend. In hindsight, I know that is a perfect name for a baby girl Garrett. How? The second hardest thing you will have to do, or the parents and family will have to do, is tell their family and friends that you just delivered a special needs baby. How you do it depends on who you're telling. Close family members were fairly easy. They consoled, encouraged you. They felt our heartache, and sometimes they cried with you. They were also there to help. Close friends reacted much the same way. They loved you and they were there. People outside of your close friends, your circle of friends, were the hardest. It was much easier to tell this group on the phone. You couldn't see the pity in their eyes, but you could hear it in the voice. Some felt heartache, some ignored the topic, and some also cried with you. My mother helped me to get over the pain. She was a no-nonsense person. I lamented, why me? She told me, Candy, why not you? What made you think you were so special? That caused a shift in my thinking. One of Bob's friends helped him, telling him, God doesn't give these children to just anybody. That helped Bob and moved him forward. It was extremely hard for me to go back to work. I knew I'd be facing other people I had to tell, and I'm not sure what I was going to do with Amy. One of my friends volunteered. She lived nearby, so I could go and nurse Amy during the day. I was thankful for the friend's support and the love she showed me and Amy. Help. We needed help. Searching for help, connecting with providers, finding supportive individuals, other parents, friends, and agencies. That was hard to do before the internet. How it happened for me was with our next door neighbor and her connections. She had an adult daughter with severe disabilities, and she was in an institution for the mentally disabled. As she had cared for her daughter throughout the years, she had developed contacts with people who worked for the Department of Health and Human Services. After we talked, she gave a friend of hers our contact information. The next day, that woman was at my home. Bonnie immediately took Amy from me and held her the entire time, talking about people with special needs, sharing resources. One of the resources she shared was the National Down Syndrome Association. I mailed them immediately and received a nice 15-page brochure. It only provided the basics. Now all of that information and tons more is on the internet. She also provided us with information on the United Cerebral Palsy of Bangor. The agency had just started providing services for disabled infants and toddlers. We made an appointment and signed up. The agency also offered a coffee chat for parents and a sibling component. We were lucky. That organization helped us immensely. That would have been a valuable resource to have when we left the hospital. Health issues. Down syndrome, they have bronchial infections, endocrine problems, seizures, dental issues, ear infections, hearing loss, vision, and sleep apnea are common. Amy has experienced all of these. She's been hospitalized twice with croup and severe pneumonia, which required surgery. She'd had a collapsed lung. There is another health issue that individuals with Down syndrome are likely to get, and it's Alzheimer's. About 30% of individuals with Down syndrome in their 50s will have it. The risk increases with age. This scares me, praying that it doesn't happen to Amy. In closing, I hope this presentation helps you when you have to face a situation where you have to deliver heartbreaking news. Make eye contact, provide plenty of information, have resources to hand out and website links. There is no easy path. Now Amy is 40, our challenges aren't over. She is a forever child. We will take care of her until the end. Ours are hers. Bob and I are court-appointed guardians. I'm her healthcare advocate and representative payee. Amy lives her own life. She's in a group home and has been since 2007. She does her own laundry, cooks some of the meals, and has an active social life. She takes walks every day, has coffee with friends weekly, bowling, which she is good at, and she makes telephone conversations to family and friends every day. If you are on her list, you will get a phone call at the same time every week or every day. I'm 9:15 daily, AM and PM. Amy has a boyfriend. She has a box for Special Olympics. She has a fan club of family and friends. If you ask Amy, she will tell you, I love my life. We should all be so lucky. Amy is a Special Olympics cheerleading squad, and they're called the Mighty Mighty Motivators. She loves being a cheerleader, and as I said, she loves her life. I've provided a list of services that would be available and contacts you might need, and they are the Department of Mental Health and Human Services, Maine Development of Educational Statutes on Individual Disabilities. Websites exist for most physical disabilities, mental illnesses, spinal bifida, Down syndrome, cerebral palsy, blindness, deafness, deformed limbs, and there are so many out there that you could check them all out. I think you should. I think it would be important, almost required reading for you to check out some of the other special needs. I hope you did enjoy this. It was going through this and writing it, it brought back a lot of the memories of that first time, that when we had Amy and how we were told. I hope you learned something about how to tell parents. Thank you.
Thank you so much, Candy, for sharing your experience with us today. So I'm going to go ahead and introduce our next speaker. So Nancy Cronin is the Executive Director of the Maine Developmental Disabilities Council, where she focuses on the development of effective services and support for persons with developmental disabilities of all ages and their families. Nancy has a special interest in effective early intervention for young children and equitable healthcare for all individuals with DD. In addition to being the executive director of the MDDC, she is also a mom of an 11-year-old son and 2 dogs. Thank you, Nancy.
I thank you, and thank you for having me here. And thank you, Candy. That was really an important story. And what I want to talk briefly about is the interaction with medical professionals and folks with developmental disabilities. Next slide. Very briefly, I want to talk about what has happened with individuals with developmental disabilities in Maine and across the country. This is specifically Maine that I'm going to talk about, but the truth is you can look at this type of timeline all the way across the country and maybe even the world. Before 1908, I don't know how many of you drive around Maine and occasionally see town farm roads. Well, there's a town farm road in almost every town or every couple towns, and that is where people with developmental disabilities or widows or paupers or people with substance abuse went to before institutions. Then around 1908, a woman named Dorothea Dix said, "This is not okay. It is not okay to put people away. We need asylums." And then that was the period of institutions. Around that period of time, we built Pine Land in Maine. And some of you probably know it's cheese. It's a wonderful wedding reception now, but that used to be the institution for people with developmental disabilities. It closed in 1996. There are many people who lived in Pine Land still in our community today looking for health care. What happened in institutions were not pleasant. People were treated like they were broken and diseased, and they were sometimes punished physically. For instance, it wasn't uncommon for people to be sterilized so they couldn't have children. Those laws are still on the books today. And I know people who have had that happen to them. They might have had their teeth pulled out because they bit somebody, as opposed to looking at the behaviors. What happened around these issues, and then probably the most long-standing challenging is eugenics, the belief that you were somehow defective if you were born with a developmental disability. And it was important for you not to reproduce and not to have lives in the community. You needed to be protected. People needed to be protected from you. This is the overall kind of history that folks lived with. And it ended in 1996. That's not that long ago. In 1996, or even before that, but in 1996, people said, no, we're not diseased. With developmental disability, that's what we called it. And we moved to a social model that said this is individual. Problem, and medical professionals didn't necessarily get a lot of training about how to provide individuals with these low abilities. And what we found is, unfortunately, care in the community. This is partially because we never really talk care in the community. Yeah.
Nancy, I'm sorry, I'm having a hard time. You're breaking up a little bit. Is there anyone else in your house using your Wi-Fi?
No, I'm in the office. I'm sorry. Is that better?
It's better now, but we're losing quite a bit of what you're saying.
What I'm saying, no, there's nothing I can do about this. So let's just cross our fingers.
Hey, Nancy, maybe you could turn your camera off, Nancy.
Sure.
There we go.
Thank
All right.
you.
Let's see if that helps.
I'm not hearing Nancy at all now.
You can't hear me at all?
Oh, now I hear you. This is like a bad.
Oh, this is a bad dream. I'm so sorry.
One of those cell phone commercials. So go again, and we'll see if it has corrected itself. It's just out of our control.
It really is. It really, really is. And okay, so what's next slide?
Okay.
All right, so what we've found with this mixture of not being able to, not preparing a lot of medical professionals for treating people with developmental disabilities in the community, and people with developmental disabilities being apprehensive of going to medical professionals, is we're finding that people with intellectual disabilities are twice as likely to suffer preventable death. Next slide. I'm going to go very fast for a minute.
Okay.
We're also finding that a lot of adults with women are not getting the OBGYN care. We're very nervous. The society in general are somewhat nervous at the idea that people with developmental disabilities may have sex. And if they might not have sex, unfortunately, a tremendous amount of people are sexually abused. So it's very important that the typical care that everybody else should have. Next slide. Next slide. All right. And this one just recently came out, February 2021. Physicians talked about how uncomfortable they are providing care for people with developmental disability. Now, that might sound terrible, but it really isn't terrible. It is important for people to recognize that those feelings are very real. And the reason why some of those feelings are real is because training were not provided. So the fact that now we're starting to say, I'm uncomfortable about this, means we can fix it. And that didn't exist before. So what are some common comorbid disorders for people with developmental disability? Well, people with developmental disabilities are as varied and different as everybody else. So any disability or disorder that anybody else might have, somebody with a developmental disability might have. But some of the things to really watch, Candy talked about, increased risk of dementia, especially for people with Down syndrome. Seizure disorders are significantly higher prevalence in seizure disorders than others. Autism spectrum disorder has a significantly higher risk of seizure, and unfortunately, death happens at times because of uncontrolled and uncared for seizures. All of this is preventable with really good follow-up. People with intellectual disabilities receive fewer diabetes exams, and yet they have a significantly higher rate. They have higher hypertension, increased risk of obesity. There is a lot of gastrointestinal issues. In fact, it's not uncommon at all for people to come into your office showing a lot of agitation, and might even be exhibiting what we call challenging behavior. But the truth is what they are is they're in pain. And the first question that I would want people to ask is, have you pooped in 2 weeks? That kind of question. Next slide. There were some studies done by Medicare that found that people with intellectual and developmental disability had higher kidney disease, obstructive pulmonary disease, heart failure, all of the same disabilities that anybody else might have. You might have people with developmental disabilities. Next slide. So here's the bottom line. There's lots of health risks. There's serious gaps in care, and these gaps lessen quality and quantity of life, and that's not okay. Next slide. So what's up with this discomfort and the gap in healthcare? Well, what's up is oftentimes medical professionals are looking at behavior that is out of the ordinary, that appears challenging. And a lot of folks don't know how to work with that. And it's really important that we get the skills so that people don't have to show challenging behaviors. I'll show you a slide in a minute about in Maine, how many office visits failed because of challenging behavior. What you'll be very interested in seeing is what doctors called challenging behavior, I would have said was probably fearful behavior or people in pain who lacked communication skills. So that's another piece of this, is people are lacking the ability to communicate to the medical professional, and the medical professional is really lacking how to communicate. The lack of knowledge, serious lack of time. That is listen. They have 15 minutes and that's it. Some patients are going to take more time. And then the question is there implicit bias in system? So we recently had that study in which doctors and medical professionals felt like people with developmental disabilities didn't have as quality of a life. So what does that mean? How did that work around COVID-19, for instance? So COVID-19, there were some questions whether or not people with developmental disability
Nancy, do you want to just take a breath and pick up again? We're losing you again.
Early in the epidemic. Oh, what a nightmare. I'm frozen. Oh.
Take a breath.
I'm so sorry.
That's all right. So
So
you were talking about early in the pandemic. Nancy, Nancy, can I interrupt you again? I'm sorry. I'm really not receiving any of your information. So Nancy. Nancy, I think it would be great if you could call in to the, looks like she is going to do that. In the meantime, we do have a video that underscores a lot of the points that she's making. So while she's re-establishing a connection with us, if that's all right with you, Doris, I think we'll go ahead and play the video now.
Hi, I'm in the waiting room.
We have you now, Nancy. Thank you for calling in. We showed the video without too much explanation, but obviously that was a dramatization of a really horrific situation as an example of what not to do. And I see that people are critiquing it in the chat, which is fantastic. So when you're critiquing it, tell us what profession you're studying or what profession you are as you're working, because it's important for everyone to learn about each other that way. That's the only way that we have to do it in the Zoom world. So Nancy, do you want to resume at your what's up with the gap in healthcare slide? Nancy is muted, Lee. Is there something you can do about that?
So what I'd like to really talk about is about implicit bias. Can you hear me?
Yes, we can hear you now, and we are
Excellent.
looking at the we're going to be looking at the what's up with the gap in healthcare slide. Is that the one you want?
Yes, thank you. And I can see you.
Ah.
This is it's just a funky, funny, awesome moment with technology. And but what I want to talk about is the implicit bias, and that's what we've found because we haven't had as much opportunity to interact with people with developmental disabilities. Sometimes there is this belief that they are somehow foreign and so different from us, and that is one of the problems with our institutional history, unfortunately, and the fact that we were just so disconnected from the community. So, but the question is if we have this implicit bias, what is the results of that? You could see in that dramatization. Was there an implicit bias of Angel's ability to communicate? He wasn't even looking at her. What is the implicit bias in the system, for instance, during COVID-19 and the many numbers of people who were not allowed ventilators during the system? Which was pretty awful. Today, we have an implicit bias around vaccines. Who gets the vaccine, who doesn't? So the question is what should medical practitioners be aware of whether or not they have their own implicit biases? Next slide. The next slide it really shows in a data dive at Maine Health about why doctor's office visits didn't work. And what we found is doctors said that there was resistant behavior of the patient. The patient struck the med staff. There was too much movement. They threw themselves on the floor. They eloped. They refused to leave. They were unable to, there was self-harm. They were verbally antagonistic. They bit, they cried. These were really interesting words that I was seeing in that database, because what I see in these words is there was an individual who was really afraid of being at the doctor's office and might have been in pain and might not have had the ability to communicate. And just that bias, that little look of how we phrase what we're seeing in front of us makes all the difference. It's a difference between this individual as being challenging and showing challenging behavior, as opposed to this patient might be afraid, have a trauma history, and not know how to communicate. Next slide. What we find in Maine and across this country is unfortunately more individuals with developmental disabilities are prescribed off-label antipsychotic medications than folks who with mental health and substance abuse combined. What you're seeing here is some quality improvement data from main care, from Medicaid. And it is shocking to me that 26% of adults with developmental disability are on these off-label antipsychotic medications. What that speaks to me is that there was a medical office visit and somebody said, please help me stop this behavior, please help me control this behavior, as opposed to what's happening underneath this behavior. Are they in pain? Are they trying to communicate what's happening? And we're throwing medication at them, which is essentially a chemical restraint. And I wanted to note that. Next slide. There's one thing I'd like to say before I leave, and I am very sorry for the technical difficulty, but if there's a key takeaway I want you to hear from me, it's that there's a long history of not providing health care in the community for people with developmental disability for lots of different reasons, most of which are nobody's fault. It's just we're at the very infancy of systems. And when medical professionals do see folks with developmental disability, then remember one thing: it is never appropriate to shut down the aggression of a communication without determining what the behavior is communicating. I'm going to repeat that one more time and then I'll stop talking. It is not appropriate to shut down the aggression of communication without determining what the behavior is communicating. I really thank you so much for letting me talk, for dealing with the awkwardness of the technology, and being interested in this topic. Folks with developmental disabilities have a lot to offer our communities, and but they can't do it without the medical professionals around them to support them. Thank you.
Thank
All
you.
right, All right, thank you, Nancy. So moving on to our last presenter, I'd like to invite Doris Babbage to speak with us right now. So she is a graduate of the Mercy Hospital School of Nursing, as well as an alumnus of the University of New England. With her experience, she now serves as the head of adult nursing services and infection prevention at Spurwink, which is an organization which provides behavioral health and educational services for those affected by IDDs. So Doris, you want to take it away? Doris, you're still muted.
There we go. Is that better? All
Perfect.
right. So we saw Candy, and Candy was very effective in giving us the parents' perspective when our communication with parents of individuals with developmental disability is ineffective. We heard Nancy talk about disparities and barriers that really help, that really block care to folks with intellectual developmental disabilities. We heard Angel loud and clear. By the way, that was a reenactment of an actual doctor's appointment that Angel had, and the doctor that was in the film was playing the role. He was not the actual role, and he had a very difficult time playing that role because he is a great doctor. Angel got diagnosed after her visit with a cancer of her GI tract. So she indeed was suffering pain in her GI tract. So what I want to do is make what Nancy and Candy talked about a little more functional. How can we improve the system? And I want to start a little bit with talk about some ethics. So ethics is very, very important. And the American Association on Intellectual and Developmental Disability has a large document on ethics. And in that document, they have 19 principles. But the very first principle that they're talking about is the principle of respect, that the professional fosters effective communication first and foremost with the individual, using all possible alternative means of communication to ascertain that their unique needs and values and choice. So there choices, their needs, and we foster it with the person. Next slide, please. So here is a reenactment of pretty much what happened at Angel's office appointment. You had Angel, a person with disability, and a staff and a physician. And the communication pretty much took place directly between the provider and the staff of Angel. And there was very, very little, except a little bit of eye contact now and then with Angel that occurred. Next slide. What should happen, nope, I need the next slide with, there we go. What should happen is this. The communication should be directly all of us, whether it's me as a nurse, a physician, an OT, a PT, a social worker, a dietitian, a dental person, should be directly with the person with the disability. And if the person with disability needs assistance, then that person, staff should be working with the person with disability to help with this assistance, not just directly ignoring them and dumping all the information, which may be biased from the perspective of the staff person. So if you're a staff person and you're making minimum wage and the client is having some behavioral issues, you want that behavior stopped. You really don't care what that behavior is doing. So the information from the staff can be biased, and we need to remember that. Or even guardians of families, the information can be people get tired, they get exhausted when they have a challenging individual. And that challenging individual has a reason why those behaviors are occurring, and that's what we should be looking for. Next. We should speak directly to the person. We should, oops, I'm trying to follow with my slides here. We should speak directly to the person, not to his or her caregiver. We should ask the person, do you want that person? Do you want your caregiver? Do you want your guardian, your parent, your friend here during the office visit? There may be need for that person to speak to their physician because things are inappropriately happening to them. They can't do that if the caregiver is there. So we should be asking that question, whether the person wants their caregiver to stay for the visit. We should ask simple introductory questions like, what's your name, and do you know what you're here for? You want to ask them to tell you why they're here today. I have a little message here. Is that better? I can't hear you, Chris.
I think you're good.
Okay, all right. So ask them to tell you why they're here. Explain the process that you're going to do. So I'm going to ask you a few questions, and after I ask you a few questions, I'm going to examine you. I'm going to want to listen to your lungs. I'm going to use the stethoscope, show them the stethoscope, explain to them what you're going to do. And you want to use very, very simple terms. You want to gain that person's attention. You want to try to make eye contact if possible, and you can usually do that by using their name or gently touching their hands. Sometimes it may be necessary to ask them, please look at me, but do it gently. Next slide. You want to determine how the person communicates. Do they speak? And if they speak, are they reliable reporters? Because if they had been institutionalized, they learned, as Nancy was saying, they learned behaviors to please the staff because they didn't want to be hurt, or they didn't want staff paying attention to them. So if you say, are you having pain? They'll say no, and they may be having pain. Are they nonverbal? Do they speak in a nonverbal way by blinking with their eyes or using sign language or a modified sign language? Do they use a communication device? Do they use a dictionary of communicative intent, which is a document that staff, family have helped the individual put together that shows how they communicate. And I'll show you an example of one in a while. So you wanna, you may need, if they actually using devices or they have special techniques, then the caregiver or parent or guardian comes in and is very helpful, helping the person show us how they communicate. Next slide. You want to show warmth and positive regard. You may have had an long day. This may be the last office visit. Everything went wrong today. If you show our people with intellectual developmental disability are extremely perceptive of how we're feeling and how we're feeling towards them. So you really, really, really want to, if you're having a difficult time before you go in to work with somebody with intellectual developmental disabilities, you want to focus yourself, take a deep breath, and kind of put away the rest of the day and go in with a nice warmth and positive regard for that visit. And the visit will be much more productive, and the outcomes that you're looking for are more apt to happen. A lot of our folks use comforters. Sometimes it's an actual item that they need with them. It could be a stuffed animal, it could be a key, it could be any type of object. And some of our folks don't sit, and a lot of them like to pace. Allowing people to do their behaviors that help them feel better about themselves will help that visit go along better too. If the person has autism, then the eye contact piece I was talking about, you may not be preferable for them because they are very uncomfortable with eye contact. So make sure for those individuals that you respect that. And you want to use positive comments and positive reinforcements. Thank you. That really helped me understand what's going on with you. So feedback to when they're giving you good information, you want to feed back to that individual the information is good. You want to focus on their ability rather than disabilities. We all of us have abilities. All of us have some sort of disability. We all have strengths and we all have needs. So we want to focus on those abilities and use those abilities to help us address the needs of the person that's coming in the office. We want to talk about the possibility of making their appointment the first or last appointment of the day, especially for folks that have problems with a lot of stimulation or have a lot of problems with people they don't know. So you bring that person into an office. Now, this won't happen with the COVID when we're in COVID, but post-COVID, if you bring people into the office and the office is full, that's frequently the first trigger for that person, and that the office visit's not going to be a good office visit. A lot of our folks don't even want to come to the doctors. They fear the doctors. So if you make them sit in a waiting room for a lengthy period of time, and then you put them into another room for a lengthy period of time, by the time you come in as the provider, that person is ready to say exit stage right, and you're not going to get what you need from that individual. You also want to consider for some of your folks with disability of avoiding the waiting room directly. Make arrangements with, when so-and-so comes in with the receptionist, they should be brought to the exam room directly. So those are kind of things that you want to individualize with the individuals once you get to know your folks, and they may improve the office visit a lot. Use plain language. We in the healthcare profession tend to have all these big words and so on and so forth. With our folks, we want to use plain language. We want to use short, simple sentences. We want to be concrete. Most of our guys are very black and white in their thinking. So you want to do things like show me, tell me, do this, come with me, I'm going. You want to think, for example, if they're ready to go, instead of saying you need to get ready to leave now, if you say put your coat on, it'll be much more effective for most. You want to think, you don't want to think do things like broad, like what are your feelings? You want to be very specific. Are you upset now? Are you sad? Are you happy? And you want to, if you want to get the concept of time, a lot of our folks have a problem with the concept of time. But if you say to them, I want you to do this before breakfast or before bedtime, that instead of, I want you to do this at 7 a.m. or I want you to do this at 7 p.m., it'll be much more effective, and you can get them to understand what you're asking for them of when you want them to do things. You want to speak slowly and in a normal tone and volume. For some reason, and even myself, I have to watch when I talk to individuals with disabilities, especially if they're in wheelchairs, I find myself talking louder. I, over the years, have done a lot better and don't do that hardly anymore, but that's, it just, people do it. So be careful with your volume. You want to pause frequently. Our folks, most of our folks have great receptive skills, but have very difficult time with expressive skills. So when we give them information, we want to give them information that is very clear in small amounts. And we want to give them time to process that information and time to respond to us. So we talk too much. We talk give them way too much information at a time. And if you break that information down in smaller amounts, it is much more effective.
Doris?
Yeah.
About 3 minutes left. Do you
All
want
right.
to move forward to a particular slide?
Yeah, let's see.
I like the
Dictionary of Communicative Intent, please.
Yeah.
So here is the Dictionary of Communicative Intent. I would advocate that all of us, for all of the folks that we provide services for, that we have this, that we know exactly how they communicate, and it's right in front of your file for that individual. So it's very clear. So like this person, he smiles when he says yes, he shakes his head when he says no, and so on and so forth. So next slide. So remember, we do have some individuals that do express themselves in writings or with pictures or so on and so forth. So we don't want to forget them. And another thing that is very, very, very effective is actually using graphs, pictures, models, and pointing to body parts. I had a great experience with an oncologist who was trying to explain to one of my clients that they had cancer, uterine cancer. And he drew pictures. And by the time she left on the way home, she was able to feed back exactly what he was trying to tell her. But he worked on her one-on-one. He ignored the rest of us literally and just drew pictures and involved her. And it was very effective. And again, I can't say this often enough. Behaviors communicate. Number one at the time, it's pain. The second is fear. And the third is unmet needs. They're coming to us. They're coming to all the healthcare providers because those behaviors communicate that. And then when we start excluding them because of their behaviors, we're not dealing with their behaviors. Behaviors are hard. We tend to be very subjective when we work with behaviors, and we need to stop that. We need to be objective. We need to use pain tools such as the face pain scale if they're able to use it. If they're not, there's an excellent tool that works well for me. You might find something else for you. But the PANAD, which is a tool that was developed for people with dementia, works very, very well in this population because it's very objective. And you use their body language to tell you whether or not they're actually in pain or not having pain. And I've used this very, very successfully. Remember, focus on the abilities, not the disabilities, and thank you for listening.
Thank you so much, Doris. That was a lot of great information, and you got through it in record time. I was able to upload the PowerPoint to the chat. So if you're interested in the resources and seeing all of the great points that we didn't get a chance to cover, you can download that from the chat and use that as you need to. This has been a very exciting event from the backstage perspective. Thank you everyone for hanging in there with us. We do have a attendance survey we would love for you to complete, and it will get you on our email list. So you'll be able to know about our upcoming events. And we do have an event on April 2nd. That's quite a long one. It's more of a conference. If you're interested in elder abuse, substance use, and or crimes against older adults, there's a great Reader's Theater case that's being prepared for that. And you can see our other upcoming events here on the screen. If you are planning to apply for the honors distinction, especially if you're graduating in the spring and you need to present a poster, please send us your statement of intent to cece@une.edu so that we can include you in the poster session. I think we're at time. And I thank everyone for hanging in with us, and we hope to see you at our future events. And I really want to take a moment to thank Doris and Nancy and Candy, especially for sharing that information with us and for really humanizing it. That the story of Amy is a very moving one. And I think I know that I learned quite a bit working on this session. Thank you to Matt and Roshan for your work all over the course of more than a year putting this together. And sorry about the technical difficulties, but I think we managed to get a lot of content to our audience today.
And thank you again to all of our guests. We also wanted to specifically thank Dr. Stacy Teamy. This would not have been possible without her, and unfortunately she couldn't be here today, but we wanted to thank her as well and give her our appreciation. Thank you everybody for coming.
All right, thank you everyone, and I hope you have a great afternoon.